So what are the indication for prophylactic mastectomy? If someone has a strong family, someone who has a strong family history of breast cancer, and if she is having BRCA1 and BRCA2 mutations, or a previous breast cancer in one breast, or breast biopsy shows carcinoma in situ, lobular carcinoma in situ, or atypical hyperplasia. These are the 4 indications for prophylactic mastectomy. Normally in UK, a mammogram is offered every 3 years for all women who are aged between 50 to 70. But if there is a strong family history or BRCA mutations, then mammogram is performed annually at the age of 40 to 70. So according to these mammogram guidelines, we can see that breast cancer is common in age above 50 in normal population. But if someone is with a family history or BRCA mutation, then it is common above age of 40. So breast cancer is not very common in young individuals. Prophylactic bilateral mastectomy or oophorectomy, removal of both the ovaries, can be offered in a patient with a strong family history and genetic marker of that cancer are raised. Then we can genetic marker of ovarian cancer or genetic marker of breast cancer and a strong family history, then you can offer bilateral mastectomy. In a suspicious breast mass that is ill-defined, remember that well-defined is benign and ill-defined is most likely cancerous. So an ill-defined mass with palpable lymph nodes, FNAC is not enough alone. You need to perform core biopsy to confirm the diagnosis, because FNAC or fine needle aspiration will only take some cells, while on the other hand, core biopsies will take a chunk of tissue, so it is easy to diagnose the breast cancer or suspicious breast mass on core biopsy. For Paget disease, it's sponge biopsy. For suspicious breast lump, initially FNAC and then core biopsy. For ductal papilloma, it's galactogram. For fibroadenoma, ultrasound followed by FNAC. So if I present to you with a lump breast and her age is less than 35, then you will go for ultrasound, because the breast of young females have extensive fibrous which cannot be visualized on an X-ray or mammogram. So in young females, ultrasound is our investigation of choice to move forward. While in females who are above 35, in them we will perform mammogram initially. Again, the screening guidelines for breast cancer, mammogram every 3 years in patient with a strong family history and BRCA genes. So the patient with a strong family history and genetic marker of breast cancer, which is BRCA1 or 2, it is also a genetic marker for ovarian cancer as well. So you can offer this patient bilateral prophylactic mastectomy. And if he does not agree for bilateral prophylactic mastectomy, then you will screen her annually with mammogram. So if after surgery, if a patient develops hypotension and tachycardia, then the cause is most likely hemorrhage or hemorrhagic shock. So in any abdominal surgery or any surgery, if the patient develops hypotension and tachycardia, or if the patient goes into shock, then the diagnosis is most likely hemorrhage or bleed. What are the types of hemorrhages? Primary hemorrhage, reactionary hemorrhage, secondary hemorrhage. Primary hemorrhage occurs during the surgery. Reactionary hemorrhage that occurs after the surgery within 24 hours due to slipping of ligatures or warming up of the patient body or dislodgement of the clots. Example is bleeding while in the recovery room. Secondary hemorrhage. So if patient is of reactionary hemorrhage, then you need to take him back to the operation theater and stop whatever the source of bleeding is. Secondary hemorrhage that occurs 1 to 2 weeks after operation. The cause is usually infection, so secondary hemorrhage will be treated with antibiotics only. Now, notes on histopathology of some breast lesion. In exam, usually they ask about the histological findings of fibroadenoma. Fibroadenoma, there are two words in this name, fibro and adenoma. Fibro means fibrous tissue and adenoma means glands or epithelial tissue. So proliferation and expansion of stroma with low cellularity. Stroma means fibrosis. Fibrous tissue forms the stroma with low cellularity, less cells, then it is most likely fibroadenoma. Encapsulated adipocytes within a fibrotic stroma. Adipocytes are fat cells. So capsulated fat cells or adipocyte that is surrounded by a fibrotic stroma. The diagnosis will most likely be hematoma, which is also a benign breast condition. Other histological description of fibroadenoma include a well circumscribed lump with clear margins. So irregular margins or ill-defined lump with irregular margin is carcinoma, and well circumscribed or clear margins are fibroadenoma. This is one hint towards fibroadenoma, and the other one is, as its name indicates, fibrous and glandular tissue, because it's a fibroadenoma. So there will be fibrous and glandular tissue. Another description, histological description that they usually give in the Plab 1 exam is duct-like epithelium. So adenoma means gland or epithelial cells that are surrounded by fibrous tissue. While if encapsulated adipocytes, adipocyte that is surrounded by fibrotic stroma is hamartoma. Or if glandular or epithelial tissues are surrounded by fibrous tissue, then it is fibroadenoma. Cystic formation with epithelial hyperplasia, then it is fibroadenosis or fibrocystic changes. Cystic formation with epithelial hyperplasia, fibrocystic changes. Or other description for this histological appearance is fibrosis or epitheliosis. Epitheliosis means epithelial hyperplasia and cyst formation. Cyst formation plus fibrosis, or cyst formation plus epitheliosis, or cyst formation plus epithelial hyperplasia, all of them are fibroadenosis. And fibroadenosis is breast pain and increased lumpiness that appears before menstrual cycle and disappear after it. So we have discussed the histological changes of fibroadenosis as well. Now, important notes on post-operative oliguria. If the urine output of the patient is decreased after operation, in UK, remember that because of the fear of urinary tract infection, Foley's catheter is removed within 24 to 48 hours after surgery. And if you remove the Foley catheter of a patient and he complains of oliguria or decreased urine output, then the first thing that you will do is to perform a scan of the urinary bladder to see the post-residual urine volume. If post-residual urine volume is more than 500, it means the patient has developed urinary retention, which is a common complication of epidural analgesia that is given during cesarean section. So if after operation a patient develops oliguria or decreased urine output and he has no Foley's catheter in his bladder, then the first thing that you will do is you will perform a scan of the urinary bladder to see the post-residual urine volume. If it's more than 500 ml, then you will reinsert the urine catheter. What if the patient has urinary Foley's catheter in place, but still there is no urine in the urine bag, or the patient is complaining of decreased urine output? Then first of all, then you will not perform bladder scan. Then first of all, you will check the patency of Foley's catheter. So a patient without a Foley's catheter develop oliguria or decreased urine output, you will perform bladder scan. But if with the urine catheter he develops decreased urine output or oliguria, then the initial step would be to check the urine catheter or check the patency of the urinary catheter. The urine catheter might be kinked or blocked. Only a simple push of normal saline can open its blockage. So if the urinary catheter is blocked, then you will give a simple flush of fluid to open it again. But if the urinary catheter is not blocked, then the reason for his decreased urine output is most likely acute kidney injury. So you will give IV fluid challenge and see if the patient's urine output improves or not. So is it clear to everyone how you are going to manage a case of oliguria after operation with catheter and without catheter? Is there any question?
Can you repeat it, because my internet was disconnected for some time?
So there are a patient complains to you with oliguria after operation. If a patient is without Foley's catheter, then you will perform a bladder scan to see the post-viral residual urine volume. If the post-viral residual urine volume is more than 500 ml, then it means there is bladder atony. That's why patient is unable to urinate. There is enough urine in his bladder, so you will only you will insert or reinsert the Foley's catheter in this case. So the initial step In a patient without catheters who develop oliguria after operation is bladder scan. While oliguria in a patient after operation who has a Foley's catheter in place, the first step will be check the urine catheter. And the urine catheter is not blocked, then it is most likely acute kidney injury due to hypovolemic or hemorrhagic shock. So you will give fluid challenge. Is it clear now?
Yes, sir.
So a patient with a tender mass near the anus. The lump is tender, swollen, erythematous, and throbbing pain that is worse on sitting. There's also fever and constipation. The patient is diabetic. So in GIT, in the chapter of gastroenterology, we discussed a mass around the anus, which was erythematous. What was that? That was perianal hematoma, I think.
Hematoma?
Yes, perianal hematoma. So when we will say that it's anorectal abscess, the mass is tender, it's swollen, there's a pain, there's fever. So all these things are pointing towards an abscess. That there's accumulation of pus around the anus. That's why the mass is tender and the patient is having fever. And again, the treatment of every abscess is incision and drainage plus antibiotics. Diabetes mellitus and immunocompromised patient are at a risk of developing anorectal abscess because of their low immunity. And one other thing, the patient with Crohn's disease can also develop perianal diseases such as fistulas, anorectal abscess, perianal skin tags. We have discussed it in the gastroenterology that perianal diseases are common in Crohn's disease. So diabetes mellitus and immunocompromised was also a risk factor for anastomotic leakage. And they are also risk factor for anorectal abscess. Now, a well circumscribed lump with clear margins and separated from the surrounding fatty tissue, there are overgrowths of fibrous and glandular tissue. What is your diagnosis? Anyone? A well circumscribed lump with clear margins and separated from the surrounding fatty tissue. Well circumscribed lump, growths of fibrous and glandular tissue. What is the diagnosis? Fibrous and glandular tissue.
Fibroadenosis?
Fibroadenoma. In
Fibroid.
fibroadenosis, there was cystic changes with epithelial hyperplasia.
Yes, fibroadenoma.
If fibrous and glandular tissue, then fibroadenoma. So it's fibroadenoma. Axillary lymph node clearance can lead to during radical mastectomy can lead to upper lymphedema because the lymphatic drainage of upper limb is done through the axillary nodes. So when we clear the axillary lymph nodes, it can lead to upper lymphedema, which can cause redness, swelling, and frozen shoulder. The treatment for upper limb lymphedema is physiotherapy and arm exercise. Now perianal fistula. So leakage of fecal content. Normally the fecal is of fecal content in an area around the anus, then it will be known as perianal fistula. It means abnormal communication exists between the skin around the anus and the rectum, which is causing the leakage of feces. So how we are going to manage a perianal fistula? If the fistula is superficial and simple and low fistula, then we will perform fistulotomy. What is fistulotomy? Fistulotomy means lay open the fistula. Just give me a minute and let me show you a diagram. Yes, the diagram, I think. So the fistula is superficial or is it low? Then we will perform fistulotomy. And if it's deep, complex, and high, what is a deep, complex, and high fistula? A fistula that crosses internal and external sphincters, like is the case in this diagram. See, this is internal anal sphincter and this is external anal sphincter, and the fistula is crossing both of them. It is a complex fistula. The treatment of this type of fistula is ketone sutures and ligation of the intersphincteric fistula tract. Again, these are ketone sutures which are passed through the fistula's tract and they are ligated. Inflammation and fibrosis will lead to the closure of, they are non-absorbable sutures, so it will lead to the closure of the fistula's tract because we cannot open this kind of fistula because they are crossing internal external anal sphincter, so it can lead to complications if we try to open the deep or complex or high fistulas. Fibroadenoma already discussed, so we'll end our session here. We'll try to finish the general surgery chapter in the next lecture, and after that there will be a mock exam of 50 MCQs, 25 MCQs from surgery and 25 MCQs from GIT. So be prepared, do and do questions of general surgery and GIT from Plabable.
So the mock test you will prepare yourself?
The mock test, I'll take the mock test. MCQs that will come in mock test will be high yield MCQ from med revision.
Okay.
So you people do Plabable on your own and Plab keys. And in mock test, I will, because the length of most of the question in the Plabable is not like the real exam. while the length in the
Yes.
med revision, I have saw med revision. I've seen med revision, and the length of the question was long, like Plavable. So you will know how to manage the time and how to answer the MCQs in 1 minute.
Okay.
I have bought the med revision subscription for this purpose. So I'll be selecting high yield MCQs which has long statements so that those can be covered as well.
So
And
should
after
subscribe.
finishing the course,
Should we subscribe
no, you
Madrid?
you don't need to subscribe it.
Okay.
The questions which are not of part of Plavable, because I have gone through Plavable many times.
Yeah.
So I know questions are not a part of med revision. So I'll be
Yeah.
uploading only those questions, or in the test only those questions will be asked, and I'll keep sharing the MCQs on the group as well. The previous two MCQs that I shared, that was from Plavable. Oh, sorry, from med revision.
Okay.
So, or at the end, if we when we complete or finish the course, then I'll share the mocks of med revision with all of you as well.
Okay.
So
So
tomorrow is the test.
Dr. Sumbal, I have shared the schedule of the lectures, and I think tomorrow there's no
Oh,
lecture because people will be on duty.
okay, okay, sir.
But to be more sure, you can see the schedule that I shared in the group. I have shared a screenshot of the schedule in the group.
Okay, sir. Now you are going to take the mock test. We need to take printout or something like that.
Uh, I think that will be online, most probably through Google document or something like that. I'm working
Oh,
that out. I'll let you know the details in a day or two.
okay, sir.
So are we going to do it together, or is it like everyone will do the mock test on their own with the time frame and then?
Everyone will do their mock test on their own because there are 50 MCQs, so there will be 50 minutes.
Okay.
And after that, you'll submit your test to me, and I'll check them out and let you know the result individually and discuss the points which you need to work on.
Okay.
Okay, then.
Okay. Thank you. Goodbye.
Okay, sir. Allah
Goodbye.
Hafiz.
Allah Hafiz.